So we're getting ready to start with neonatology. I kind of work backwards on how I teach this, teaching pediatrics and neonatology, and then we'll talk about OBGYN. I cannot compete with a dog. That's okay. Dogs are cool. So we are recording this lecture today as we're moving through. So there are PowerPoints and everything else. So as we're going through them, let's get started here. Now, as you've already learned, babies move through different stages of emotional and physical development. A little bit as far as some terms and some age ranges. When we refer to neonates, we're talking about infants that are less than 1 month old. Those of you that are doing your clinical, when you go into the hospital and the baby is born, then it's classified as a neonate. Newborns are from or infants, infants are from the second month on up through the first year. Now, here's the thing to keep in mind. When you have an unscheduled delivery out in the field, remember you got at least 2 patients, okay? You've got the baby and you got mom, and then you may have family members that are your secondary patients that you've got to also manage and take care of, because calling those family members could either become your best friends or your worst enemies. And we'll talk more about that when we get into OBGYN emergencies. Now, let me ask you guys this question. What kind of emergencies might you expect with an unexpected, or you might experience with an unexpected field delivery? What would be some of the things you might run into? Rihanna, what would be one?
Breach.
A breach, okay. And so there's not much that we can do about a breach in the field. The OBGYN doc will either go in and try to reposition the child, and if he or she cannot, right, then they'll go in and do an emergency C-section. Very good. What else? Say it again. Premature baby. If the baby is premature, what is your biggest let me back up. If the baby is premature, what are your 2 biggest concerns? Say it again. Yes, and what else? Well, yes. Along with that, but we would also be focusing in on hypothermia. Okay. Now, again, remember, newborn babies have brown fat as opposed to adults who have yellow fat. Okay. Yellow fat is a really good insulating material, so it helps to retain heat in. Brown fat is completely useless as far as insulating material. The baby will lose that brown fat over the course of the first year, and it will be replaced by yellow fat as it goes on. So respiratory and hypothermia are 2 things that we want to begin to look at.
Hypoglycemia.
Say it again.
Hypoglycemia.
Hypoglycemia is another area because, again, anytime that you've got a child that is in crisis, it just gobbles up the glucose like crazy, Danny. Now, keep in mind that particularly a newborn or a neonate cannot store glucose nearly as well as you and I can in the liver. So we've got to watch that, and we've got to watch that really, really closely when we're taking care of the patient. Aziz?
Are premature babies more susceptible to infection?
They are, okay? Premature babies are very susceptible to infection. But now here's the thing we've got to remember. We want to try to make as clean of an environment as we possibly can, but understand that a pre-hospital delivery is really, really messy. Any of my EMTs in here, I guess you're all EMTs. Any of y'all delivered a baby yet? You have, okay. What was your experience like, Miriam? It was super gross, yeah. I like teaching, in the past I've done some high school EMT classes. And when we talk about the childbirth, I love to just sit back and watch the faces on both male and female students is there. And I like to think that I have helped to contribute to the birth control population of that teenage group. So yeah, you're exactly right. There's a lot of mess. Put a gown on. Obviously, you're going to have gloves. Put a mask and a face shield on, okay? Because you don't know, Benin, where the fluid is going to go. Your assessment of a baby is the same as an adult. Begin with your ABCs first. And again, I know you've heard this before, Taki, but I'm going to say it again. Any cardiac problem, look for a respiratory cause, okay? Look for a respiratory cause. Now, most of the time when we're dealing with kids, particularly newborns, we don't really have to worry about anything, Colin, other than stimulation and drying them off, maybe suctioning the airway out, as well as make sure that they stay warm. Now, in my career, I've delivered 14 kids, 14 babies. 14 babies.
How many of those are named after you?
None. Not a one.
That sucks.
Not a one. Only one of those was a critical delivery that went into cardiac arrest. I can remember, again, when I was working down at the little hospital on the Tennessee border, Jellicoe, we were transferring Mom to University of Tennessee Hospital. And I remember asking the OB doctor, any possibility this lady's going to deliver on me between here and there? Is about an hour transport. The lady said, nope. I can remember the doctor's name, Dr. Woodring. Okay, I can't remember what I had for breakfast this morning, but I remember her name. Dr. Woodring said, nope, there's no possibility she's going to deliver. 15 minutes out, this lady delivered, and the baby was in cardiac arrest. I was not happy. But
Did the baby live?
no, nope. And it wasn't premature. Mom was having some problems with eclampsia, and Jellicoe's a really small hospital, and that's why they were transferring her out. And this was prior to the time of helicopter, or else we would have flown her out. Tiger, did you have your hand up?
Yes. So for premature babies, the mom need to have steroids before. Do we have that one in us? Can we use it?
Mom needs steroids, but that's generally an in-hospital thing and not a pre-hospital thing. But now, because you brought it up and everybody else, why would Mom be administered steroids if there's a concern about the baby being born early? Nice critical thinking activity. Taki.
So they can develop their respiratory things faster or something. I don't understand it really well, but it's related to respiratory. And it's immature.
Steroids are given to the mom, not for the mom, but for the baby. And the steroids help to reduce any inflammation within the respiratory tree as the baby is continuing to develop. Now, it's not going to help the respiratory system, the pulmonary system, to develop any faster. Okay, time is the only thing we can do is time staying inside of mom to do that. But what it does do is it helps to reduce the inflammation. So if the baby is born early, there's a better chance of survival because the baby will be able to breathe. Good point.
Is there anything related to the hypoxemia in their lungs, as they have a high pressure in their lungs?
Very high.
It's so that I can't remember which side will be. It will be the opposite. It will be the right side in the heart, which with the most pressure.
It would actually be the left side because the left side is the largest ventricle, so it would be a higher in particular on the left ventricle.
But their lungs are closed.
And that's why the left side would be higher because remember, the blood you're having to pump and you're getting less fluid coming in there. So, all right. So again, kind of keep in mind when we're looking at this, just a small number are going to need assistance. If you have to deliver a baby, and we'll talk more about this in OBGYN, don't panic. Ladies have been doing this for thousands of years, and most of the time, your delivery is going to be uneventful. Okay, only about 1% require extensive resuscitation. All right, mom's going to do most of the work. Actually, mom's going to do all the work. That's why they call it labor. Okay, now what can you do if you've got a preterm infant, either delivered in your ambulance, or you may be transferring a preterm infant. What can you do to modify your equipment for little teeny tiny baby size? Where'd the dog go? Oh, okay. I like dogs. All right. What can you do to modify your equipment to fit this little tiny baby?
What?
You can do what now?
No.
Okay.
Use little things.
Yes.
Is that what you're asking?
You can use little things, but keep in mind, a premature infant may fit in the palm of your hand. Now, we're not even talking about a 7-pound baby, which would be about a normal sized baby. We're talking about an infant here that has been born that is like 32 weeks, 36 weeks, that when it comes out, it fits there. Your equipment, what about your laryngoscope? What are you going to do there? How are you going to manage the airway?
There's a pen.
Say it again.
There's a pen. You can cut it.
So you could try nasal cannula, but again, even your infant nasal cannula is probably going to be too big. But you're on the right track.
Like a
Blow by oxygen, okay? We want to kind of keep the oxygen from getting into the baby's eyes because it can cause some long-term sight problems leading up to and including blindness if we have high flow oxygen getting in there. So again, the big thing we want to look at here is to reduce your equipment to fit the size of the baby because the baby is not going to expand to fit your equipment. So again, when we're looking at preterm births, we're looking at any birth that occurs between 20 and 37 weeks. And typically, the age of viability is considered anything beyond 28 weeks. Anything younger than 28 weeks, its chances of survival are slim and none. Okay, I'm not going to say none because there are some documented cases of where you've got 26, 27-week-old infants that have been born that have survived. The problem is they grow up to have both physical and mental and emotional problems because their body is not fully developed. Right.
So if you needed to manually ventilate a premature, how would you do that if they don't fit in the mask?
If you got a premature infant and you got to ventilate your patient, you get out your infant BVM and you go, this is covering from the top of the baby's head down to his neck. Now what do we do? That's a good question. I like that.
Possible to
Just put it down.
intubate with like small things, makeshift things, and then connect them.
Your smallest tube is not going to go into this baby's trachea. We're talking about a trachea that is a little bit larger than, say, the very tip of this marker.
You can take the
What did you say, Rihanna?
Can we just move it over down?
Move what down?
The mask.
So that would be one thing. Try to reposition the mask. But now again, when we're ventilating the child, our biggest problem there is going to be in quite a many cases that mask is going to cover the baby's eyes. We really don't want a lot of high flow oxygen going into the baby's eyes. So moving the mask down would be one. Heard somebody over here.
Can we take their eyes shut?
All right, so we could indeed tape their eyes shut, okay? Watch the type of tape you're using. Make sure that you're using pretty much the same type of tape that you utilize for your IV. So that's a good thought. What else?
Can I use a glove and just press it, like position it in their mouth?
You're never going to get a seal. You're never going to get a
With my
seal.
hand, like,
You're never going to get a good enough seal to raise. Because remember, we're coming back to what you said. The lungs are really, really tiny. And so you're going to need increased pressure in order to expand them.
You know the top of like ET tubes? Can you like take that off and attach to the edge of the BVM? Oh, that sounds weird. Because it's a small opening where it has to fit inside the ET tube, but it fits
Right.
say into the.
I'm not sure if I'm following you there. So where would you put the
You know how when you
adapter?
You know how when you like bag an ET tube, the attachment to the ET tube.
Uh-huh.
How about just unattach it from the ET tube and just attach it there and use the opening in the bag? Can you do that?
Potentially, but again, the big problem is going to be getting the seal. Now, you got to think beyond coming backwards to basics. Back in the old days, we didn't have these fancy things called BVMs, and we did mouth to mouth. So you could take potentially an O2 cannula, put it next to the baby's mouth, cover the baby's mouth and nose with yours, and ventilate the old-fashioned way. Okay. Again, try to find out as much of the history as you can with your mom, because I remember a very good friend of mine that I worked with down in Knoxville, and he actually died on Christmas Eve delivering food baskets to some of the patients that he had transported. He did mouth to mouth on a baby that was meconium stained, and mom had AIDS, and so he was concerned about that. He was not infected, but again, this is one of those situations where the likelihood of that happening, Landon, is very slim. But when it does happen, you got to think really, really quick. So never hesitate to kind of think and play the well, what if game when you're thinking about different things that you're looking at. These are some of the premature risk factors that you're going to see. In particular, things that you need to understand about is number one, hypertension, which can lead into preeclampsia, that can ultimately lead into eclampsia, can cause a premature birth. The big thing with eclampsia is, remember, mom is seizing. Well, like I said, we'll talk more about this in OBGYN. But again, when mom is seizing, what is she not doing?
Breathing.
She's not breathing. Who else is not breathing?
The baby.
So the baby's getting no oxygen. So we want to keep mom from going into eclampsia and then coming into to apnea for the baby. Diabetes of any type, gestational diabetes or a history of diabetes, will often, number one, cause a premature birth, and number two, cause a large baby. I have heard of births of with moms that have been diabetics, not gestational diabetics, but regular diabetics that have had babies that have weighed 10 plus pounds. Those are only delivered by C-section. Okay, only delivered by C-section. Maternal age, very young, or what we, I say very young, and then I turn around and say very old. Actually, older than 35 is not old at all. But when we're looking at this, it's those parameters. Now, one of the nice things about medicine today is that women in their 40s are having healthy pregnancies, whereas in the past they were all considered high-risk pregnancies. But now it's kind of like no big deal. And that's a very, very good thing. If she has had a previous preterm birth, she is more likely to have another preterm birth. And then the last bullet there are lifestyle things that make the mom less healthy that would come into play. Within the premature delivery, generally what we're looking at here is these kids are going to only weigh about 1.5 to 2 pounds, which would basically wear out to be about a half a pound or a half a kilo to 2 kilos. So they're going to be really small, have low body weight, which means low respiratory issues and low body temperature issues that's going to come into play. Kids that are healthy, like I said a little bit earlier, generally are going to weigh over 7 pounds, which about 3.5 kilos as far as you're looking. And they have a survivability of those that are equal to those who are just normal full term. It is possible that you can have a premature baby that weighs up above 5 pounds. And so when that happens, that increases the possibility of them being viable and living through the delivery process and being okay. One of the things that you will note, and I want you to watch for this, particularly as you're going through your OB rotations, is watch and see if you have a premature birth and look at what the baby looks like. It will come out looking like an old man or an old woman. The skin will be very, very wrinkled and very gray, especially on the arms as well as up on the face. They may have diminished amounts of hair because the hair has not had time to kind of grow in there. When these kids are born early, again, respiratory depression is going to be our biggest thing that we're watching for, hypothermia, as well as any type of a brain injury that's going to come about as a result of them being hypoxic. Now, keep in mind, Colin, that these kids can have a brain injury and there's no trauma involved, again, because there's not enough oxygen to the brain. What would be one thing that you could possibly notice, Sydney, in these types of babies that would, because you're not going to get a blood pressure on these kids. Blood pressure would be up if they've got a brain injury, but what might you notice in these particular children?
They're not reacting to things.
So that would be one thing. They would not be very reactive, so they're going to be really lethargic. What else? Say it again. They would have a weak pulse, but now think of what it would be that is inherent to this little guy right here. Say it again. The fontanelles. Good. So look at the fontanelles. Now, again, when full-term babies are born, their heads come out like this. They look like cone heads. All right. So don't be afraid when you do your first delivery and you deliver a cone head. Okay. If you don't know what I'm talking about by cone head,
It's weird.
Google Saturday Night Live cone heads and you'll see some videos there. It was a routine. Hilarious. But with those kids, within about 24 hours, the head begins to take a normal shape. These kids don't come out as cone heads, Danny, because they're too small. Okay, so the head has to shape to come through the pelvic opening for a full-term kid, but with these kids, you don't have to. So just like Mona said, look at the fontanelles to see if you have a curvature over them so that you can identify if you've got increased pressure in the brain. Now, let's be honest, okay? For a premature child, pretty much the only thing that we're going to do is we're going to provide BLS life support. We're going to try to get IV access, which is going to be really difficult, even using an IO. Because remember, their bones are going to be tiny, tiny, tiny in diesel therapy. We've got to get them to the appropriate facility, either by ground or air, whichever one is going to be the quickest. Okay. And so if all you do is provide respiratory support and we manage the airway and their body temp, then you've done a very good thing. Now, coming back to what Rayhana said a while ago, these kids will often have a really low blood sugar. That shouldn't prevent you from trying to treat it. But if you're going, let's say that you get a good line started, it's going to have to be an IO, all right? What percentage of glucose are you going to give this child?
10%.
Why? Why are you going with 10%?
Because it's not going to be as thick as the 50 would, and it's easier to manage and not shove them into hyperglycemia.
Okay, I can go with that. What are you going to do as far as your IV? I mean, which flavor of IV you're going to use? You're going to be LR? Going to be normal saline? Say it again. I heard something.
I see the LR.
You said LR. Okay. Would anybody go with D5? Why? But don't say, well, because I think that's what I want you to say.
Well, it's going to be more diluted than any of the other ones. And they're a tiny little body, so you don't want to give them too much sugar.
So here's the thing that I would say. Now, I'm not saying you're wrong. D10 is going to be your fallback. But what I would tell you to do, Because what we have in here is we've got a glucose problem. Start out with D5 because the last thing we want to do is to swing that blood sugar way up again because that can cause additional swelling in the brain. And if the brain is already hypoxic, we've got enough swelling going on. So I would tell you to start with D5, check the blood sugar again. If it has not come up in about 10 minutes, now your next choice is going to be to go ahead and give them D10. And the nice thing about that is that D10 will bring it up. The D5 will keep it up. I'm going to go to Miriam and then Rayhana.
What's the normal blood sugar for this age?
Same as an adult. Same as an adult. Basically, what we're looking at is somewhere between 60 and 100. Rayhana.
If they're awake, like if they can't breathe, why don't we just give them oral glucose?
Now, keep in mind that they're awake, but we're not sure these kids are ready and able to manage their airway. So again, we're kind of thinking forward into the future. Well, if I give them this oral glucose, it's really thick, and if it begins to mix with their own saliva, now that may potentially cause an airway issue. So that's why we would hold back off of the oral glucose. But here's the thing I like is that my big thing is always start with the simplest appropriate treatment and work your way up. So I like the way that you're thinking. All right. Anybody else?
I just heard about the glucose thing. So, as far as I know, kids shouldn't neonate and infants shouldn't eat anything like sugar, salt, or solid food. Or anything. There are more things in the first 5 months.
Well, that all depends between the mom and the doctor, but basically, the best food for a newborn for the first several months is going to literally to be breastfed by mom if she can. It serves several different purposes. One is that it is the highest in calories, so that's what the baby's going to need. Number two, it's the highest in nutrients, and also there is something there about the physical bonding between mom and baby that, from an emotional and mental perspective, helps to build up that relationship. Good point. Again, when we're looking at this, the degrees of immaturity determine how the child is going to look. Again, if they're born really, really early, then we're going to run into problems with this baby looking like a little old man or a little old lady that comes into play. Keep in mind, again, babies that are born have brown fat, but they have less of it proportionally than what we have as adults. And therefore, particularly premature babies will have translucent skin that will almost be like you're able to see through it. You're able to see vessels and things through it. I'm going to tell you, you're not going to get an IV started the traditional way on these kids. Not in the arms, not even if we were to go with an IV in the head. So again, just simply go ahead if you're going to do that and you're going to go with an IO. The other thing that comes into play here is remember, their chest wall muscles have not developed to the point of where they should be. What kind of problem does that lead to? Increased work of breathing, okay? And we can work safely off the assumption that their diaphragm is in the same situation. So again, all premature babies should be identified as respiratory components. And here's the other thing. Even if you are able to get positive pressure ventilation to your child, understand that the lung tissue, the alveoli, are going to be thinner than normal. And so you got to be really careful about only seeing that chest just barely rise any, or else we could create, just simply through using a positive pressure ventilation, either mouth to mouth or the BVM, create a tension pneumothorax for a patient. Okay. Now, the care that you're going to give from a premature baby, as far as possible, is going to be the same thing that you're going to do for anybody else. As we've talked about here, airway circulation and hypothermia is the thing that you're going to focus in on. How would you keep a baby warm? What do you do to keep a baby warm?
Towel or
Towels and blankets. Okay, now we're talking premature infants here now. Okay, so keep that in mind. All right, towels and blankets. What else? Say it again. Turn up the heat. Doesn't matter how hot it is outside. Kick the heat up. If you've got a premature child, that child is going to get hypothermic. Sydney.
Could you put like a hot pack under like a towel?
Mm-mm.
Or is that too much heat?
With an infant that's full term, yeah, that would be a consideration. With these kids, no, because remember, their skin is very, very thin. And so it doesn't take much direct heat to literally cause a first or a second degree burn. No hot.
Can we give the mom, the baby to the mom and she can hold
That's what I was.
I'm happy somebody said that. Now let's think about this for just a minute. Now remember, we're talking preterm delivery. Are you going to give this baby to mom to hold skin to skin?
Yes.
No.
Why not?
Because their skin is thin.
Mm-hmm.
Sensitive skin.
Because they're fragile.
What should be
Because of what?
They're fragile.
And
Small.
and
It's dirty.
To infection.
no, we're not too much concerned about infection at that point in time, because remember, we're not in a sterile environment, just in the back of our truck. I mean, sometimes the back of our truck's the nastiest place that you can be, but we want it to be as clean as possible. But again, remember, this is a premature infant. You're going to be busy monitoring and maintaining the airway. You can't do that when it's up against mom. Now, if this is a normal delivery with no problems like the majority of them are that you're going to have, then Rayhana, yeah, 100%. Put baby to mom's skin, allow the baby to start breastfeeding, wrap the baby around the mom. Yeah, you're good to go. But we want to make sure that we're not going to put the baby with the mom. The other thing is, some OB kits come with these, but put a little cap, a little baby cap, much smaller than the one that you've got there. But if nothing else, if you don't have one, we can make one out of bandaging material. Just wrap it around the baby's head so that it serves as insulation to hold the everything in there. Your temperature in your ambulance should be, and this is kind of an estimate. Now, we don't measure our temps, but think about the temp in the ambulance being right at about 100 degrees.
Oh my God.
Okay. Now, think about your ambulance is 100 degrees when it's 100 degrees and 98% humidity outside. You are still likely to deliver a cold baby to the hospital if it's premature. Okay, so kind of keep that in mind. Generally, we're not going to do a lot of medications with these children because of IV access and problems with being able to give them medicine. You might though, okay, and then keep in mind some of these things are going to come in to where you may be working in an ER where there's delivery takes place, where they just walk in and now they don't have time to transfer them back out to OB, or you may be involved in a transfer. Bella.
What if you have like this situation? Would you call for like another ambulance because you have two patients, or what if it's like too critical and it's going to take them too long to get there? Are you taking both?
Good question. There's no hard and fast answer for that. I think you've already answered your question. Number one, if you've got a second unit that you can get there, then you would transport one per unit. If the baby is critical, okay, I would probably transport mom and baby in the same unit. Now that presents all kinds of problems.
What if they're both critical?
Well, it depends upon how far you are from your hospital, as well as how far your backup is away. So again, that's where we hope we teach you how to critically think. That's what you're paying that big tuition for, to decide. Okay, very quickly, what's the best for my patients? Okay, if your backup unit is 30 minutes away and you're 15 minutes away from the hospital, you take them both to the hospital. If your backup unit is closer, then you would wait for your backup unit and manage them on the scene. Good question. Call.
If the baby's critical, you're transporting with the mother.
If you've got a backup unit, I would transport them in separate units because you're going to need the room to work on the baby. Okay, you're still going to need somebody in the back with you as well, especially if the baby goes into a rest or the heart rate drops down below 60 to begin compressions.
That's one
Man,
thing
you
that-
guys are a bunch of chatty Cathys today. I love it. You're doing it because it's my birthday, aren't you?
Yeah.
You're not getting any extra points.
Okay, so that's in the truck. What about if it's at home?
What about it?
What will be different? Like if you deliver it at home.
Well, if you deliver it at home, now remember, many times you'll start in home, and then you got to decide when do I move mom and or baby out to the truck. So again, you would put the baby over in an area of where you can work, and then you would work on the baby. If mom and baby are both critical, you're basically working kind of like of a mini MCI event here, where most of the time it's going to be you and your partner, and you've got two critical patients, and you multitask. You go back and forth. Bella.
What if you have twins and they're both critical?
Mm.
How are we discerning which one we're treating?
Which one do you is
Which
cuter?
one's more viable?
Which one's cuter?
Which one's cutest?
Yeah.
That's messed up, man.
Oh, that's cold. That's
You
cold.
gotta pick. You gotta be truthful.
I don't have an answer for that because, again, that takes your MCI event from 2 to 3. And again, if mom is having twins, the biggest thing that you would see, because twins are considered a high-risk birth, so if she has had prenatal care, she's probably going to be in the hospital prior to the due date, and they'll induce her. They'll cause her labor to start. Twins are always going to be less than a normal weight. So rather than a 7-pound child, you'll probably have maybe 2, 3.5, 4.5 pounds. But again, because they've stayed in utero for the entire 40 weeks, everything has developed correctly. They're just small for their size. In that situation, literally, Bella, you just do the best that you can. Okay, good. Yes, right.
How do you secure a premature?
You don't. You obviously it's going to be an emergency going into the hospital. Even if you have, there are certain devices that you can use to secure pediatric patients either to the stretcher or to your seat. Those are going to be gigantic. Literally what you have to do, again, is hope and pray for the best that there's no swerving, no accidents on the way in, because that baby is going to be unsecured. I mean, there's no way you can take care of it, because, again, if you've got a baby that is that size and your strap is that size and you're having to deal with the respiratory issues, then that strap's going to be in the way. So, yep.
If you're like transferring the baby, could you just like take the little box thing that they're in?
Yeah. So now if you're transferring, but now again, here's the problem with a transport isolette. That's what you see up here. Well, this may not be a transport isolette, but it looks very much like this. And this is a premature infant, so you can tell it's very, very small. The problem with a transport isolette is, again, the baby is not secured in there.
It's slightly more secure. It's like if it's in a
Well, it'd be like a pinball bouncing around in a clear box.
Better than bouncing out in an ambulance.
What's that?
Better than bouncing out in
Better than bouncing. I love you guys having a glass half full philosophy of that. So, yeah, you're right.
But
All
like,
right.
could you actually just like take the box so it's a slightly less scooting room
I've
for
seen
them?
I've seen transports where they take the box between hospitals. Like they
Now, what do you mean by box?
Like the little
Like that.
plastic thing that holds.
Oh, yeah. So if you're transferring a premature or even a full-born, full-term infant that's having some problems, it will always go into an isolette. Again, one of the big reasons is this will make it much easier to maintain body temp. Okay. And again, where do you transport? You go to the nearest appropriate facility. If you can get them to a children's hospital, that's where you're going to go. If you don't have an airway, you've got to go to a place that will get you an airway first. Okay? So, some of the things that we begin to see here, let's talk about newborns. Normal newborns. This is just kind of a little picture of how nasty these kids are when they come out. They're covered with amniotic fluid, all right? And so the amniotic fluid itself is also partially made up of the baby's urine, okay? And so,
I
as
didn't want to know that.
yeah, but I felt like that you needed to.
Oh, wait, did they defecate too?
We'll talk about that in just a minute.
Oh,
Yes, meconium.
I heard, like,
So babies make three big changes as far as their physiology at birth. Number one, when they're born, they empty the fluid out of their lungs. Now, here's what happens when the baby is born. As the baby comes down the birth canal and as it's passing through that small opening within the pelvis, remember, at that point in time, they're not breathing on their own. Mom is doing everything for the baby. The baby has their own heartbeat, but the baby is not breathing. When that lung or that chest gets compressed, it signals baroreceptors in the baby's body. Say that 3 times. That there's pressure change. And then when it's released, when the baby comes out of the vaginal canal, the baby will almost always should start crying. Now remember, Bill's number 1 rule is what? Okay, here's Bill's number 2 rule.
What? There's a second?
Yes, a crying baby is a happy paramedic. That means you got an airway. Okay, so if this baby comes out crying, that's awesome. That's exactly what you want to hear, because that crying is now helping to expel some of the fluid, some of the amniotic fluid that is within the baby's alveoli. And that amniotic fluid is there as a protective mechanism, because if it wasn't there, guess what? Alveoli goes like this, and it requires a much higher pressure now once the baby comes out, Taki, to open up those alveoli. So that's going to be one of the first things that happens. Second thing that happens, and we'll talk more about this in a little bit later, is that their circulation changes over both in regards to mom as well as within their own heart to more of a normal circulation. Keep in mind that the blood flow basically goes, for the most part, directly from one side of the heart to the other as far as the perfusion goes through what's called the foramen valley. And we'll talk more about that just a little bit later on. But that begins to close up. So when you hear people say, they said, my baby has a hole in its heart. Well, all babies have a hole in their heart, but that normally will close up. If it doesn't, they'll take the baby in for surgery in about a week and close that up. Sydney.
How long do you give the baby to cry or breathe before you get concerned?
If they're not crying when they come out, we start irritating the baby, because trust me, when they become teenagers, they're going to irritate you. Okay? So how do we irritate the baby? All right? No. We don't hold the baby up by the legs and slap it on the bottom. Okay? You've watched too much bad TV. All we're going to do, go ahead.
Rub their chest.
You can flick the soles of their feet, and we're not flicking any harder than this. But no, I saw that. But the part of the thing, first thing is you got to do is you got to dry this baby anyway. The baby doesn't like that, okay? And so in the process of drying and flicking the soles of the baby's feet, that should stimulate the crying response. If the baby doesn't start crying really quickly, and by really quickly, I'm talking about within about 30 to 60 seconds, you got to start ventilating, okay? Because that's an indicator that the baby's not breathing.
And should I do I don't know what's called, the back thing, like you hit the back with?
No, well, we only do back blows if there's an airway obstruction. Again, as we get more into the infant part, we'll talk about that. But now, you will do compressions if the heart rate drops below 60. Okay, even though there's a heart rate there and you can feel the pulse and you can see it on the monitor, 60 is not sufficient for cerebral perfusion. So you want to kind of remember that.
Do we have to hug the baby up down?
No, don't do that. Don't do that. That will cause spinal damage. And in addition to getting you into court, it'll generate an awful lot of paperwork. Okay, because the baby, remember, the baby's neck has not developed. It has very little muscles. It's mostly a head on its shoulders. And if you lift the baby up like that, literally, it could potentially cause really severe damage to the cervical spine. So again, leave it lying on its side. Again, on its side to help some of the amniotic fluid drain out, and then go in and dry the baby. And then if that doesn't work, just flip its feet there a little bit. The third thing we see in here is going to be a change in maintaining their body temperature. By body temperature, Mona, I mean their body temperature will have a tendency to drop down. Why? Because they're outside the friendly confines of their mother's uterus. Their mom helped to keep them nice and warm, both from an internal perspective of the baby, giving the baby warm blood, and the mom's body temp as well. Now, when do we cut the umbilical cord? Well, that depends. Once you've got the baby out and you've got it dried off and it is crying, look at the umbilical cord. The umbilical cord will pulsate as it's still attached to mom. A change will begin as the result of hormonal changes. It will send a message to the mom's body that says, okay, you've been responsible literally for this baby 9 months. Now it's time for the baby to be on its own, and you will cut the umbilical cord then. Where do we cut the umbilical cord? Well, you want to come out from the baby. Baby's over here. Umbilical cord's coming this way. You want to come out a minimum. Keyword there is minimum of 6 inches. Okay? And clamp it. Your OB kit will have clamps in it. Let's say that you're doing a delivery outside of the hospital and you're like at Walmart. I don't know why you go to Walmart. I hate that place. Let's say you're at Costco. All right? And you're literally all you got is just you, all right? You can take your shoelaces and tie them around the umbilical cord, and then you'll find something else that's sharp at Costco to cut it. But again, you come out a minimum of 6 inches, clamp it. You come another 2 inches beyond that and clamp it. And where do you cut in the middle? Or not in the middle, but what you want to do is you want to come over closer to that second clamp. Here's why, all right? When this baby is born, if you need IV access, guess where you're going? You're going in through the umbilical vein. Why is it critical that we have plenty of umbilical cord? Because guess where that umbilical vein goes directly to?
Liver.
It goes to the liver, okay? And we want a fairly long IV cannula to go, or catheter to go in there. If we have too short of an umbilical cord and we jam that catheter up in there, Miriam, now we cause liver damage. That's why you're much safer to have too much cord than too short of cord. We'll talk about how to do umbilical catheterizations, and we'll actually practice some of that over the course of the summer. Now, a couple things that happens that helps this baby to empty out the fluid. Adrenaline will activate the sodium channels within the lungs themselves, and this is why the baby comes out screaming and crying, which is a good thing, okay? So it increases the catecholamines, which now help to eliminate the fluid from the baby's lungs. Again, that comes about because the sympathetic nervous system has now kicked into place, and now it's beginning to throw this fluid out of the lungs. About a third of the fluid is expelled just during the delivery process itself. Okay, now The newborn will take its first breath in response to both chemical and barometric changes within the body. The baby, just like you and I, will sense, Ryan, CO2 levels are going up. So the chemoreceptors say, hey, you better breathe. We got to get this CO2 out. And the changes in the pressure inside the chest will also stimulate the baby to begin to breathe. Now, as that air comes into the alveoli, all right, the capillaries that surround the alveoli that up until this time had been basically collapsed, Rayhana, now they open up and circulation begins to go around the alveoli. And now the diffusionary process that we're utilizing right now starts. The baby's breathing in oxygen, it diffuses over to the red blood cells, CO2 now diffuses out, and then it goes on out to the cells. Again, when these kids are born, quite often they'll come out with cone heads and they'll look like Smurfs. They'll be very, very blue. Often they'll be as blue as your t-shirt. But again, that should begin to go away in 60 seconds or less. Taki.
So at this point, they think that connect to the aorta will start to shrink or just...
Yeah, so it will begin to close. And it will be, if everything is okay, it will be closed completely within about 12 hours. This is one of the reasons why your baby, when you deliver it to the hospital, may still have cyanosis of the extremities. That's okay. That's a part of the normal process. But again, with a normal delivery, we want to monitor SpO2 and we want to monitor end tidal. Now, you may have to get creative if you don't have an infant end tidal circuit on your truck. I'm going to tell you, unless you deliver or transport babies on a regular basis, you're not. So you're going to have to get creative with that. Bella.
So, say it's a long transport time and you also deliver the placenta.
Yeah.
How do you do that?
So, real quick, because we'll have a separate section on delivery. When the placenta is delivered, you put it in a plastic bag for the OBGYN to look at, because what they want to do is they want to look to make sure no tissue has been retained within the uterus. If there is, what they'll have to do is go in and do what's called a DNC procedure, dilation and curettage, basically to go in and scrape that tissue out because it's dead tissue and it can set up sepsis for the mom. All right. Now, yes. My goodness, you guys, I love this.
I guess we'll just wait till that.
Let's wait until that for the delivery part, okay? Now, the foramen ovale, as you asked about a while ago, it begins to close quickly, and it will close up completely in the normal delivery in about 12 hours. So as we're looking at this, a normally healthy newborn baby may not, as far as, this is one of the things you have to keep in mind, is these, their SpO2 may be 90% for the first 24 to 48 hours, okay? Again, why? Because the body is in this transition period. Normally, if we've got a patient with a 90% SpO2, we're going to be concerned and potentially even begin bagging them. For a newborn, that's probably going to be normal. So it may take a couple of days for that to come into play, for it now to begin to go back up to be a normal above a 95%. So what are some of the things that they're really, really concerned about as far as sensitivity? Number one, hypoxia. These kids can get hypoxic really, really quick. Number two, some of the conditions that we see for hypoxia, especially during the delivery, is the compression of the umbilical cord. We'll talk more about that in the baby delivering section. If mom is a drug user, especially, and it doesn't really matter whether it is an amphetamine or an opioid, that child can come out very, very hypoxic and already be born with hypoxia. and brain damage. We'll talk a little bit later on in this particular session about neonatal abstinence syndrome, of what you would see that of a baby that's born to an opioid mom. Ryan.
Can a baby be born in an overdose?
Oh, yeah, very much so. Let's say that mom just took a narcotic prior to delivery. Not a, generally they're not going to give moms narcotics for pain in the delivery process. Your baby can come out as overdosed as mom. And so I don't know if this is your all's questions or not. Yes, we would use Narcan on that baby. But remember, we've got to reduce the amount that we're giving the baby, because if we give the whole dose, now we're going to create an airway problem because of the liquid. Rihanna and then Miriam.
So can we administer morphine to my baby?
Why would you, you're talking about if they're in withdrawal?
Yeah.
No. Unfortunately, you can't, because morphine, the greater danger at that point in time, the baby is uncomfortable and it's in pain, it's in distress. But if we give morphine to try to offset that, there's a good possibility we'll make the baby stop breathing. Miriam and then Sydney.
How would you differentiate between normal respiratory distress for a kid versus like overdoses if you don't know the history?
So this would be something that we would see quite frequently with mothers who don't have prenatal care. So the question is, how would we differentiate the difference between overdose respiratory problems and regular respiratory problems? We don't care. We just know, number one, there's a respiratory problem, and we go in and we deal with that. Now, again, if we suspect that the respiratory issue is as a result of a narcotic, then we can administer some Narcan. I don't even know the weight-based dose for Narcan. This would be when, again, you're going to be that good paramedic that's going to carry some kind of reference guide on your phone. At some point in time, I'm really hoping we get Hand Heavy for you guys, because that is the best pediatric reference guide that's out there, and you'll look up your dose for Narcan. Here, and then here.
I think, do you mean like right off the bat they wouldn't give the baby morphine? Because when I was in mother's...
Oh, no. We wouldn't give morphine. So when we get the baby into, and they're going to go into what's called a NICU, neonatal intensive care unit. Those people are the experts. So are they going to give that baby some narcotic? Yeah, because what they got to do is they've got to calm the baby down. Because again, the baby is going through withdrawal. He's been cut off from his supplier, and the baby is definitely going through withdrawal. But one of the big things, Miriam, coming back to your question about the difference, is maybe it's not a respiratory problem, but kids that are going through NAS, neonatal abstinence syndrome, have the most soul-piercing, blood-curdling cry that you will ever hear. I'll see if I can't find some YouTube videos and share those with you, but there's the normal baby cry, which makes us happy. And then there's this cry that says, this kid is in extreme discomfort and distress. It's not going to kill the baby, but no baby should have to be going through that. And once you hear it once, you'll never, ever forget it. Bella.
I was just wondering if the Roslow tape would still work for premature babies.
To a degree. To a degree. Most places are now moving over to the Hand Heavy system because it's much more accurate. Show of hands. If you're working for an EMS agency, how many of y'all are using the Hand Heavy system? There. Okay. So the Hand Heavy is a weight-based system, and it goes tied to an app. Now you might have heard some of the folks as we were talking. I know Chief Butcher mentioned the fact that they had a color-coded pediatric drug bag, but they didn't buy it from Hand Heavy because it was a lot more expensive because they had all the different drugs and all the different weight bases. And so you simply look up the weight base and immediately it tells you all the drugs that they have in the system, the weight based for that particular child. And as far as your weight goes, you really only have to be close. You don't have to be 100% on. Devin.
So back to the child being born to like a drug user. Will that child like be addicted as it grows older, or does that go away?
As a parent of 4 children who were addicted to mom and dad who had drug and alcohol abuse problems, the answer is yes. It is going to be a rough life for both that child and for the parents. And in many situations, those children are taken away from the mother and put into foster care and or adopted, such as what we did. We adopted 4 kids, had them home a month, found out my wife was pregnant. So in a period of 8 months, we got 5 kids, and all 4 of our kids had all different types of problems. I had one son that died a week after his 16th birthday, again because of a malformation within the heart that none of us were aware of. Had another son that died about 2 years ago from a drug overdose. Again, the sins of the fathers coming back. And the 2 girls are fairly normal, but they have their own emotional type of problem. So yes, it's going to be a rough way to go for them. With kids, again, watch that body temp. The larger body surface area makes them at a much higher risk of losing body heat. So that's going to come into play. Kids, basically, now remember, we talked about the fact that babies don't vasoconstrict very efficiently, but they try to conserve their heat through vasoconstriction, which is not very effective, and by increasing of the metabolism. What gets used up? Last question for the day. What gets used up quickly in an increased metabolism?
Oxygen and glucose.
Oxygen and glucose. So you want to watch your child for hypoxia, and it comes right back to what you said earlier, Rayhana, and you nailed it. Watch this child for hypoglycemia. As a result, if we don't, they can become acidotic. They can become bradycardic, which is what actually happens with kids, and they become hypoglycemic.